I think we've got a few attendees now on the call this evening. So I wanted to firstly say thank you all so much for your attendance. And we're really excited to just present the federal budget and how will it impact your medical practice. So now at the moment, we've got a couple of practice owners. I think I saw a good friend of mine as well, who's a soon-to-be practice owner, come on board. And we should have a few more registrations. I'm sure they'll trickle in as they finish their shifts for the evening. On the call with us tonight, obviously, is myself. I'm Abraham Regulin. I'm the CEO and also a senior financial advisor here at Affluence 360. We've also got Rob Dixon, who's a chief operating officer over at Cubiko. Rob is one of our partners at Cubiko. So we've got the partner program with Cubiko, and they've been doing a really good job in terms of helping our practice owners and practice managers and GPs with managing the day-to-day of their practices. And also in attendance is Bob Greaves, who's the head of our tax and business advisory, and he'll be going through some of the changes of tonight's, the federal budget from last month. So just some of the topics that we'll look to cover tonight. Obviously, the federal budget highlights, giving us an overview of the changes from the budget that will affect your practice. And then Rob Dixon will deep dive into benchmarking, how this will be affected by the budget, and more excitingly, some tips and tricks on how to forecast future billings from changes in the budget. Off the back of that, we'd love to hold a bit of a Q&A or more of a fireside chat, I guess, with all of the attendees and some panelists, speakers as well that's on the call with us. Just to ask any questions as well, and we'll see where we can help. But we'd love to make this evening's webinar as interactive as possible. So we've also got a Q&A panel on the top toolbar on your Teams app, or if you're on a mobile device, at the bottom, you'll see 3 dots at the bottom there. If you click on that, there'll be a Q&A panel as well. So feel free to jump on, ask any questions that you have. We'll collect that and we'll cover that off at the Q&A at the end of the webinar. So without further ado, I might get Bob to kick off with the updates from the federal budget. Bob, over to you.
Thanks very much, Abraham, and thank you all for attending tonight on what I would describe not only an auspicious occasion, given that Queensland will be holding up the trophy tonight, the State of Origin trophy, but also the fact that today, if you hadn't noticed, is the winter solstice, or if you're in the Northern Hemisphere, I don't think we have too many tonight from that. It's the summer solstice, shortest day of the year, so I won't spend too much time wasting too much more of your time. So in terms of the 23-24 budget, it's probably the budget that's had the biggest impact on GP practices in decades. So when we look at some of the numbers that are involved, they're quite large, although I must say that the $5.9 billion, and it sounds like a lot, is over 5 years. And I don't know why they want to sort of throw out the big number and put it over 5 years, but 5 years is sort of how they handle a budget from the federal point of view. Everything is put in terms of 5 years. So if you really want to look at that, it's 1.2 billion a year. So it's not as big as what they'd like it to be. But let's get down to the nitty-gritty of what that is made up of. So 3.5 billion on bulk billing incentives. So those breaking into about 4 different parts. So the first piece I look at and I say, yeah, so what? Which is the increase in the level A to D rebates. So I'm sure you're all familiar with the A to D rebates, so I won't go into too much detail on that, but the key one, which is the level B, which is your 20-minute consultation, the increase there is 4%. So it's 4% across your level A through to Ds. So it's 4%. So basically on your average level B consultation up to 20 minutes, $39.75 to $41.40. Given that we're running a CPI of 7.1%, That's pretty weak, I would have thought, but next time I was speaking to Elbow, I'll have a chat to him around that. Now, the second piece is the new level E consultations. Once again, don't know how important this is going to be, and probably Rob later on will chat about this, and we'll look at this as a potential opportunity. But I'd imagine at the moment, the number of 60+ minute consultations is probably in very small single figure numbers. But I guess then again, they are looking to increase that number. The third and probably the most important piece here is the tripling of the bulk billing incentives that are made available for children under 16, that's 15 and under, and pension and concession card holders. So on an average, triple M1 Metro practice consultation, that means $6.60 up to $20.65. So it's tripling of that amount. We'll go through some of these numbers at the end of my presentation, just to give you a feel for how the numbers actually stack. The final piece on bulk billing is further incentives for longer telehealth GP consultations. So we'll put that on the never for now, because it's not really, I can't put numbers around it. And given that I'm the numbers guy here, I'll kick on. Next slide, please. So the other piece is outside the bulk billing piece, which is just increasing funding globally. So what they would call providing access to primary care with coordinated teams. So we've got the 500 million multidisciplinary teams assistance to assist GPs, recruit nurses and allied health professionals. So the maximum available per clinic annually is 130K. So we will look at that around a Q&A session and just what we might be able to do in that sort of space. That's probably the biggest kick in here. Some of the others here, 144 million, incentives to encourage GPs to stay open longer. I'm sure you're all wanting to work longer hours, so I'll kick on to the third piece, which is connect frequent hospital users to GP practices. Once again, pushing public billing, public patients to GPs, which is part of their why. And finally, a little piece on spending on enhancing chronic wound care through subsidised wound supplies and training. So another 50 million in that space over a couple of years. Next slide, please. Now, when we look at the why, I could be as cynical about this and say that the biggest thing here that I can see is about pushing public patients to private practice. There's nothing wrong with that as long as there's enough money provided to you guys in private practice to deal with that. And you know, it is a big number, and that's where we're sort of in that space, just trying to work out whether that is enough to make you want to change your behaviours and your hours and your practices to accommodate that. So the three pieces through improving sustainability of the Australian health system is improving access to primary care services for families and benefits, family and benefit recipients, alleviating the pressures on public hospitals, particularly emergency departments and hospital admissions, and finally, and this is probably the most important to you guys, improving the stability or viability of bulk billing program in the GP practices and GP practices. So they do think about you guys and how are you struggling to really increase your margins and in some cases just keep your practices up and running. So I'm a pretty simple guy. So if we look at the next slide, I look at the bulk billing, which is the majority of the money being spent, 3.9 billion. And I look at an average private billing of $85. And at the end of the day, that's it's not a bad piece of money, but compared to the metro bulk billing rebate, where you're getting under the new standard level B rebate, $41.40, and then we're kicking in another $20 for your incentive. We're still coming up a little bit short at $62.50 to the $85 that you would be receiving if you're able to continue to private bill your patients. So there's still a gap there in my mind that hasn't been filled by the government in trying to incentivize private bulk billing over private billing. So the question then therefore comes back to, yes, the gap has been shortened, but there is still a gap in that place. So is it enough to stop the last 18 months sort of falling in bulk billing within the practices across the board? And I'm sure Rob will go through some of these numbers. We've had a falling roughly of about 85% to about 65% in metro locations over the very quick period of time of 18 months. So will that, question mark, and I'll pose this to everybody to think about, will that change the number of bulk billings that you're going to look at? So with that, I'll hand back to Abe, and he'll introduce Rob.
Yep, absolutely. Thanks for that, Bob. Appreciate the presentation there. So guys, I wanted to introduce Rob Dixon as well. So he's the Chief Operating Officer at Cubiko. Brings a practical and hands-on approach drawn from 7 years working in the healthcare industry. And his focus is on providing tools and insights that make a real difference in the day-to-day running of GP practices. So as mentioned, he's put together a bit of a presentation for us. And Rob, love for you to take over the screen and yeah, jump on board.
Perfect. Thanks, Abe. Thanks, Bob. No, I appreciate that. I think Abe has an easy time with Bob and Rob, so it's great in terms of the webinar today. Awesome. So I hope is that coming through all good? The slide. Yeah, perfect. And I can see there's a few Cubiko customers. I can see Sean there and probably a few others. So yeah, lovely to see everyone tonight. And I'm excited to, as Bob mentioned, I'll kind of take some of those points that Bob took around what the impacts were the practice, and I'll focus in on them as well as sharing some of our industry benchmarks that Cubiko does through our feature called Touchstone. So I'll cover that off today. So looking into what is Touchstone and what is more broadly Cubiko's benchmarking. So effectively, Cubiko is a practice intelligence platform. We integrate with a practice's practice management software, namely in general practice, BP, and medical director. And then effectively, we are across around 1,500 practices across Australia using our software. And around, I think 700 now have opted in their data to provide the benefits of industry benchmarks. So it's anonymized and de-identified. So everything here I'll be sharing today is averages. So really take it in line with kind of in reference to your own practice, and you know your business the best. So everything today is just really around averages and so on. And then this is our team. So this is the Cubiko team. These are the people who work to build out those benchmarks as well as our product every day. So effectively, when a practice opts in their data, we ask for their state, their modified Monash model, their PHN billing model, whether they're a teaching practice or not, and their doctor FTE size. So it allows them to kind of compare apples to apples when they're doing that comparison across the benchmarks. Also, just so you're all, as I mentioned, around security, yeah, the Touchstone benchmarks are completely opt-in. It's completely de-identified or even unidentifiable in terms of whose data is what. It is aggregated across the entire sample size. There are frequency and cell dominant rules, so no one can actually figure out specifically metrics in terms of what this practice might be. We round the data, and also minimum practice size count randomized, which means that a practice up the road could not figure out another practice down the road's data from the benchmarks. So just wanted to kind of cover that off from a security and privacy perspective. It's core to who we are at Cubiko. So the data set, the data that I'll be running through today, what that comes from is a sample size of 640 practices. So we pulled this last, we looked at and analyzed this last in May 2023. The sample size, 72% of the practices are mixed or private billing, and 28% are bulk billing. So that's just the sample size within our Touchstone data set. So take that as well when you're looking at the numbers. In terms of the size of the practices, 5 to 9 GP FTE is and 2 to 4 FTE are the dominant, I guess, size of practices within this sample size. So also just take that into account when you're looking at the numbers and understanding them. Cool. So the budget, sorry, there's some slide transitions on here that are catching me a little bit off guard, but it's okay. The budget. So effectively, the three, Bob covered over some of the major impacts to the budget. The three that I want to focus on was the addition of the level E, the 4% standard increase in standard consults rebates, and the bulk billing incentives being tripled. So firstly, I thought it'd be good to set the scene, and this will actually help go into the Q&A after that Bob mentioned around that we're all thinking about today is, was the point of the budget to help reduce bulk billing rates? Do we think there's actually going to be that change there?
Medical practice. How are you?
Oh, sorry. I think Pete's just...
Not too bad. I just missed it.
Yep, thank you. Someone's just muted Pete. Perfect. So the Touchstone bulk billing rates, what we're looking at there is number of bulk billed invoices over a number of invoices. So when we're looking at this number, effectively this is how many invoices practice would bill and percentage of those bulk billed over time. You can see in the top line the overall bulk billing rates and how they've declined since May 21. You have a couple of variations throughout the year, namely January, February, the overall bulk billing rate goes up because of CDM. Generally, practices tend to line up their care plans with the start of the year. As you can see that the standard consult rebate doesn't go up. And then the standard consults and the overall bulk billing rate also goes up in April, May, June, namely because of flu shots or COVID vaccines and so on, which you'll all be doing now. So you see the bulk billing rates across the Touchstone data set have significantly changed over time. And then we are starting to see it to bottom out a little bit or go up because of, again, January, February, and March at the start of the year. So bulk billing rates, I thought it was important to then look at that over the modified Monash model because that also helps understand the tripling of the bulk billing incentive and how that may impact your practice or practices in general and bulk billing rates. So here's the bulk billing rates across each modified Monash model. Namely, you can see that MM5, MM6, and 7 are still significantly bulk billing, whereas practices in your metro area generally have much lower bulk billing rates. Now, that could be due to a number of reasons, whether that be the different population at those practices and demographics in terms of patients. It could be due to supply of practices in regional areas and metro and so on, or just propensity to pay and valuing healthcare and so on. So with the addition of level E, that'll be the first one that I'll look at in relation to how that may impact your practice. One of the things we did with the Touchstone data set when we analyzed it was looked at the average number of level D consults that practices were billing per month that were going over 60 minutes already. So effectively, across Australia, the average practice bills 16 level D consults that are greater than 60 minutes. A mixed billing practice bills 15 per month, and a bulk billing practice 18 per month. So what does that tell us? Effectively, a practice that if you're a mixed billing practice, you could effectively expect, based on averages, that the introduction level E consult may lead to an additional $990 billings per month, which isn't much, as well as the bulk billing slightly more, and the Australian average being around $1,000 a month. So that's just from the introduction of level D to level E. But again, that's national averages. You would know your practice best. For instance, my brother's a GP in Melbourne. He does a lot of mental health consults, and I know that he will benefit decently well from a billings impact from the introduction of the Level E, because he does have quite a few consults that go over 60 minutes. I know a lot of other GPs would barely have any consults that go over that go over 60 minutes. So again, you would know your practice best and yourselves and GPs best, but effectively the average a practice could expect in billings per month is about $1,000. So that's the average there. And we wrote a blog post all about the Level E consult and that, which you could read there. But if you wanted to, the other part of my presentation today is around forecasting. If you did want to forecast out that for your practice, it's a feature in Cubiko. We built like a couple of metrics around the budget and bulk billing changes, but you would have to look at effectively number of Level D consults you have, where the appointment is longer than 60 minutes, and then apply that new rebate, $183 instead of $117, and see what that billings impact may be for your practice. So next is the 4%. Minushi just asked what the bulk billing rebate is for a Level E. It was on that previous slide, but we can also, $183. So the standard consults had a 4% increase, as Bob mentioned. So those numbers are on there as well in terms of the increase there. Effectively, when looking at forecasting these changes, you would have to look at the total number of consults that you would have across your A, B, C's, and D's. And then again, this is a feature within Cubiko. So if you're a Cubiko customer, you'd be able to find this metric there. But what it would look like is effectively the number of consults you may build across those standard consults over the last 12 months. Factor in the increase and then see what your billings increase is there. We don't have any touchstone benchmarks across this particular metric. Anecdotally, though, the data on this screen is not the touchstone average. This is just a demo account. But yeah, anecdotally, you'd see a decent amount of billings increase for the practice. If you wanted a simpler way to see if it increases your practice, you could look at how many standard consults do and just apply 4% increase and see, and then apply that to your total billing and see if it'll make that change. But it'd be slightly less, again, depending on your billing mix within your practice. Next is the tripling of the bulk billing incentives. So why this is interesting, because if we look at the bulk billing rates previously that I showed across the modified Monash model regions, where your 5, 6, and 7 were still quite highly bulk billing practices, especially across, I would also say that would weight even more across the incentive eligibility types, like your pension card holders, your concession card holders, your 15 and unders, which is what this incentive is for. That patient base most likely is still being bulk billed in regional areas. And so regional practices in those regions that have a large increase, because it's a base tripling, 300% increase of the already rebate, they would benefit higher from that. So if you're a regional or rural practice in those regions, yeah, you could benefit. The caveat though is, and this ties to Bob's point before, is also around what your private fee is. So for instance, and what private fee you're charging for those same eligibility types. For metro practices, anecdotally, it could impact your practice, absolutely, if you are bulk billing those eligibility types. So concession card holders, healthcare card holders, and pensioners and 15 and unders. So how would you look at this? You would look at your relevant bulk billing incentive item numbers, for instance, like your 1090s, your 1091s, and so on. They're all different depending on your region. And then effectively, you want to get a report, how many of those did you bill over the last 12 months? And then you would look at that and you'd effectively triple the rebate. And that could give you an idea of how this affects your practice. Again, this is a metric. This is one of our metrics that in Cubiko, but just an example. If you wanted to forecast that, you'd have to generate a report from your practice management software and look at how many of those rebate item numbers that you're charging already. Historical data in this sense is useful to understand the impact on your practice going forward, but if things are going to change for you in the future, you also want to take that into account when forecasting. So I mentioned before, you want to take into account your private fee. So this metric in Cubiko also looks at, for instance, your percentage of consultations item bulk billed across those eligibility types that we spoke about. But also then what is your bulk billing rebate? So again, this is just demo data, this screenshot, but you can see here, for instance, my average fee is around $20 from this practice in my demo data. And so I would actually, oh no, sorry, the new bulk billing incentive rebate is about $21 because I'm an MM1. But the average gap for a healthcare card holder and pensioner and slightly for senior card holder healthcare cards are actually higher than the new rebate increase. So if we were to start bulk billing those eligibility types, this practice would actually do less billings. But with the bulk billing increase, incentive rebate of being about $21 and my average private fee of being about $11 across 15 and unders, we can see in this example, this practice would increase their billings for 15 and unders. So again, just take into account what your average fees are across those eligibility types, and then what the increased rebates are across those eligibility types. In this example, it's the same. So one question I thought would be great to answer with the Touchstone industry benchmarks is around what is the average fee of a 23. And so we did analyze this, and probably no surprise, but it's around $80. So that's again across all of Australia. And think back to the sample size that we had within the Touchstone average. You know, it's slightly weighted towards medium-sized clinics. All the clinics use Cubiko. All the clinics use best practice. All of them are that's slightly weighted towards mixed billing practices and so on. So just think of that when you think of this number. But the average fee is about $80, and it has increased over time. So it's increased from about $76 to that $80 since May 21. And I think has it increased as much, you know, with inflation? No, we can see that from at least this data point, which is where it's useful then if you're looking at your private fees to take into account as well your patients, what they're able to afford, with how they also the value of your healthcare that you're providing to patients, which is the great thing about a mixed billing practice and mixed billing as well. And then also, what the increase in your cost base is, which Bob and Abe know much better than I would there. So looking at how you're forecasting these changes to your practice, you can review your billings, say for the last financial year, last 12 months, and look at those changes there. Calculate the increase. How would it impact your billings? Add it together and so on. And then you can also figure out what your weekly increase might be. This is useful if you're doing some financial planning for next financial year. It's useful if you're selling your practice and will your valuation go up by 4% if your billings go up by 4% by this. So it's just like taking different considerations into account when doing this forecasting, whether it be beneficial for you or not. What we do have, and hopefully I can chuck this in the chat, is Cubiko developed it's just a free download, but it's like it's an Excel spreadsheet essentially. I'll just chuck that in the chat, and if you guys are looking to do some forecasting, welcome to then download that, and hopefully it helps you on the way in relation to your forecasting your MBS billings and the changes specifically from the budget. So there's one other benchmark that we're looking to watch quite closely in relation to just billing changes and how this would affect practices. And that is the billings per hour. Because what we're looking at is effectively, will the budget or bulk billing increases aggregated across the Touchstone dataset effectively increase how much a GP would bill per hour of their time? So when I say hour, I'll explain that a little bit, just because general practice doesn't really have an agreed definition of what an hour is, which is why Cubiko breaks it down to about 3 different hours. But effectively, an hour, when I speak in terms of an hour, what Cubiko is looking at is effectively the time that GP did with patient-facing appointments. So think of it like, let's say you're in your own diary as a GP, you had 8 appointments today. oh, sorry, not 8 appointments. Let's say you had 8 hours of appointments today. An hour of that, or maybe half an hour of that, was a non-patient facing time like lunch or admin or other things like that. Then you'd have 7.5 hours left of patient facing time essentially. So Cubiko would then look at your total billings over that 8-hour session or 8-hour time over those 7.5 hours. So that's what we break down in terms of our product. But yeah, when I look at billings per hour, we're specifically looking at time spent with patients, not total working hours, not total session hours, not total booked hours, more around consulting and patient-facing time. So the average in 2023 across Touchstone is around $347. That's the Australian average per consulting hour. Now that differs greatly across practices and their billings mix, their bulk billing or private billing, skin procedures, what type of care they're providing as well there in terms of those services and the MBS item utilization. But yeah, the average is around $307 per hour. So a mixed billing practice would bills slightly more than the average, around $354 per consulting hour. The Australian average, as I mentioned before, is around $307 per hour, and a bulk billing average across the Touchstone data set is around $327 per hour. Probably not too surprising there, but what is surprising is it is increasing the gap. We looked at this data last year, and it was, I think, about a $10 difference between a bulk billing practice on average, what they'd bill per hour, and a mixed billing average practice and what they would bill per hour. And what we're seeing now is that billings per hour, the gap between a bulk billing and a mixed billing practice is increasing. And that's why we're interested to see with the federal budget and other measures that come through for practices and everything else, will that gap continue to widen, or will the gap start to come closer together? But it also depends on mixed billing practices, and will they continually to increase their fees and so on. You guys who I'm sure are running amazing mixed billing practices probably answer that question better than I can. And so here we can see that larger increase has really been to the start of this year. So this trend graph looks at the start of May 22, where we see billings per hour. And we can, as I mentioned, the gap between a mixed billing and a bulk billing practices are much closer, whereas it's starting to widen. Again, probably not too surprising, but generally speaking, a bulk billing practice may do more chronic disease management, which is why you can see the bulk billing clinic has a much larger difference, a more drastic increase in billings per hour in January. Generally, I would say that's because of chronic disease management and the utilization of 721, 723s, and so on. But since that period, you can see that the gaps starting to widen between bulk billing and mixed billing practices really since the start of the year. I think mixed billing practices often may look at their fees at the start of in December and look to increase it January. Probably June, July as well is probably another common time for practices to increase their private fees. And it is good generally to look at it multiple times and have incremental increases for mixed billing practice and private fees rather than large increases once at a time. What I thought I'd break down though, because it's interesting, because plenty of GPs on the call around is 370 per hour. The whole time I speak to that was gross billings. So if GP at 65% split or 70%, you can see there roughly, okay, well what is the take home there for the GP, as well as the service fee charged by the practice for providing services to the contractor GP as well. So just thinking of that is, well, let's say the average service fee is around 30%, which Cubiko does not have any averages on that, so I can't comment, but let's say it is, $104 per consulting hour. So effectively time with patients, if the practice is getting about $104 per hour, that does exclude other income like PIP, path rental, government grants. I'm sure a lot of you have applied for the Strengthening Medicare grants, or further on, other income may include My Medicare when we get more information about that, or the government would like to give more information about My Medicare, that'd be great. But generally, you can kind of get an idea of what the average practice gets per hour or per hour with patients. One other thing, I don't have the link for this in the chat, but you can scan it with your phone if you'd like, is we have some, just like a general practice dashboard where you can download that as well. And if you don't use Cubiko, it helps with your benchmarking and just understanding, what were the averages across that time period, and then kind of helping you analyze your data to see how it compares. So it covers some of the benchmarks that I looked at today, as well as others. It's just like a free download that you can download from there. And I may have run a little bit short on time, and I'll figure out where Teams is. But yeah, that's a lot of the industry benchmarks from Cubiko, and also how that affects practices. And yeah, I'll throw back to Abe, if that's right. Oh, Abe, you're
on mute. Most famous saying on webinar.
on a Teams call.
Yeah. Awesome. Can everyone see my screen though? Hopefully I've got this down pat as well. Wonders of technology.
Yeah.
Amazing. Well, sorry, Mel.
Yeah, no, I know Keegan just mentioned he's got to jump off because he's probably got to head off to church. But there's a couple of questions. I think we already did answer. Mantella Road, any idea what the rebate on item E will be? I've just written a comment in there. $183.66 is the estimated for that.
Yeah.
The second question from Keegan was, will the increase in bulk billing incentives be phased in, or will it occur in one go? And when will it occur? So when is it going to take place?
Great question. I think from the tripling of the incentives, that most of it's going to take place from 1 November. But I do believe there are also some other incentives that will be phased in. Bob, I'm not sure whether you've got any other answers to that, but we can definitely look into it. And
No,
Yeah,
that does.
no, I thought it was around that date too.
amazing.
I assume it's got through. I'm assuming the budget's all been approved firstly, but
Absolutely. All right. Well, we do have some other questions as well that we've prepared. So I think, Rob, given you've just done the last briefing, how do you think doctors and practice managers could best take advantage of the budget changes?
Yeah, definitely. I think, yeah, to be honest, I think I was saying this with speaking with Bob and Abe a bit earlier, and Mel, and I think it's a good budget. Is it an amazing and great budget that will drastically impact practices? Probably not. In time, that could be more. It is nice to have tripling of the bulk billing incentive. But practices that have already made the mixed billing switch, or existing mixed billing practices, and charging, like Bob mentioned, charging a fee higher than $80, you're probably not better off. But yeah, it just depends. How can practices make a change in it? If your fee, looking at those incentive items, eligibility types. So if you have different fees across 15 and unders and across pensioners and healthcare card holders and concession cards, and if that fee is lower than the standard rebate increase and the your bulk billing incentive increase, then yeah, you'll be better off, which is great. So depending on how you're billing those patient bases, essentially.
Clearly, Rob, there's a skew towards the higher the MMM number, i.e. the further away from metro areas, the greater the incentive and the bigger impact on bulk billing. And that's clear in the numbers as they stand anyway. You've got, I think it's MM 5, 6, 7, all averaging about bulk billings in the high 80s and 90s. So and I think that's probably going to continue where they're probably going to be, it's almost going to be 100% in some of those locations, and due also to the demographics of some of those locations. So probably a little bit different to metro locations where you're going to be discriminating against, continue to discriminate who you provide that to, and obviously the government wants you to continue to provide it to those that can't afford it at the end of the day.
Yeah, definitely. I think it's great that practices that do mixed bill. The patients that can afford it paying for it, value the services practices are providing, and rural practices. Yeah, I think it's also great that they are getting more from a greater increase from the bulk billing incentive, because I'm sure that'll help sustain rural practices, throughout Australia as well.
Yeah, definitely. I know we've got some of the doctors here. This might be a really good question for you. Obviously from the level D to level E, the new consultant there. How do you think we could best take advantage of that moving forward? I'm not sure if Minushi's on the call still, if she's dropped off. If there's anyone else that
No, I'm still here.
Okay, Minushi, there you are. What are your thoughts on that, Minushi?
I mean, it's 183. If I do the math, I'm really not good at math, as you know. I think as a private billing practice, if I can actually, so a standard consult is $85. So 1 hour, that's 4 patients for me.
Yeah.
So if I do the math on the 185, if the bulk bill, the current, increase in 4%, it'll be, if it's bulk billed, it's $45, which is like 4 standard consults bulk billed. If I can actually increase this in the private billing to reflect 3 standard consults, yes, I'll do it. But me personally, I don't like long consults. I just want to do 4 quick ones rather than the long. I don't see us doing many of them, but maybe one doctor at the practice who does like a lot of mental health, like Robert's brother, and does like to talk long, etc. But I don't see him billing privately for these. Most patients would stop at, if you say 185 for a long consult, someone will be happy.
Yes.
Our level D is 190, and they get about 113 back, whatever the rebate is, but we rarely do them. So probably not going to be something we use often.
No, absolutely. Thanks, Minushi, for that. Your thoughts there. I think another interesting one we had was obviously looking at the funding for multidisciplinary teams. So the $130,000 incentive per practice. Bob, what are your thoughts on how the practices could best seek funding for that, and where to use it, more importantly?
Oh, look, at the end of the day, it's kind of, can we employ more nurses and other allied health professionals to do tasks that are at a cheaper rate than taking on, taking the time of expensive doctors and registrars. I think that's, where we can look at cutting costs and bringing those guys into the business. But it's also a case of, are there process improvements in our sort of head office speak, if you like, where we can improve the flow of patients through the practice. I think we discussed one where, if I look at a specialist where you go to a cardiologist, and they have the nurses doing probably 2/3 of the work. They're taking your blood pressure, they're getting you on the treadmill, etc., etc. And then you might see the cardiologist for 5 minutes, who just wraps up based on the information provided. That doesn't work for a 10-minute or a 20-minute consult, but it may work for some of the longer consults where we're using the registered nurses to do some of the work, that instead of using the doctors to do the same work, as an example.
Yeah, absolutely. I think that helps as well with the patient experience, so instead of having to sit there in the waiting room, they're actually being seen and moving along that process.
Yeah.
Quite well. Another thing I thought I might ask, Rob, if I could get your thoughts on the bulk billing decline. So I noticed, obviously, we're at 85% in terms of the number of practices, but over the last 18 months, that's dropped down to 65%, I think is what I wrote down for metro areas. What are your thoughts on that? And do you think that's something that will continue to decline?
Yeah, definitely. I think so I'll comment firstly on potentially why it's been declining over that time period, and at the rate it has, and then I can comment on do I personally think it'll continue to decline? Firstly, general practice, we haven't had increases in our fees in private bulk billing rebates for many years, and inflation and everything started increasing in the last 18 months, 2 years or so on. Not just that, but like the media and the public perception of inflation has also greatly increased, and I think that has helped practices transition from a bulk billing to a mixed billing model. Over that time, the practices, were able to have great conversations with their patients and increase their fees and so on. Because we actually saw drastic changes in months like July, where a lot of practices choose a certain period, like end of financial year or coming into July, to go from bulk billing to mixed billing. So I think there's like a number of forces that helped practices move towards that. Now we're getting to a stage where, and not just that, but the decline increased in velocity at a pace when more and more practices were mixed billing. So it helped with patients in general understanding, well, if practice A down the road is mixed billing, I'll go to practice B down the road that bulk bills.
Yeah.
Practice B also then mixed bills. Well, the patient is now, in a way, more accepting. I think patients should just be happy to be able to see a GP for the services provided, but now they're more accepting of mixed billing and so on. And so when more practices, it's kind of like that self-fulfilling flywheel in a way, where more practices mixed bill, then more practices mixed bill, and there's a velocity there. I do think though we are starting to bottom out in a sense. Not that practices are going to, I don't believe this budget will heavily impact practices to start bulk billing at a greater rate drastically. I think for some incentive type eligibility types that we spoke about, it could, and I think it will greatly aid rural and those region practices, which are great. But like we spoke about, mixed billing practices that have a private fee set at a point, they're not going to benefit for an from the bulk billing tripling incentive increase, and therefore, probably will not start bulk billing again for those incentive items, patient eligibility types. Sorry. I don't think it'll continue to decline at the rate that we've seen. I think it's starting to bottom out a little bit, and but I don't think it's going to go back up either.
No, fantastic, great insights there.
We've just got another question. Sorry. So Manishi's heard that the government is talking about taking away the 723 and consolidating it just to 721 items. Is there any truth to that?
I might tackle this one. Manishi, I'm not a government whisperer, and I don't know if Abe or Bar either. I don't know if there's any particular truth to that. I hope with anything that the government looks to strengthen chronic disease management item numbers, like your GPMPs, your TCAs, your reviews, and so on. I do hope the government chooses to strengthen those items if they do look to make changes to them. I don't know about decreasing though. There were talks a while ago with the Strengthening Medicare Task Force linking your chronic disease management items to patients enrolled in My Medicare. So we don't have much information officially out by about My Medicare, but effectively what was in the budget was practices can enroll patients who are frequent flyers in emergency departments with My Medicare, and then you get a $2,000, I think it's a lump sum payment, maybe annually, and then they get an additional $500 with every reduction in an emergency visit for that patient. There's no information about, as far as I'm aware, since we're looking at it a couple of weeks ago, there's no information about how that's going to work, because you think of data in the hospital system about presentations to emergency departments, getting back to a funding model, back to a general practice. That's a pretty tricky thing. But in terms of changes to GPMPs and TCAs, the only thing I've heard on is related to the Strengthening Medicare Task Force and potentially linking that to a practice can only provide those services to patients who are enrolled via My Medicare in their practice. But no, as far as I'm aware, no official information has come out about that. Sorry, that's kind of a roundabout way, but that's the only changes I've had there, Manishi.
No worries, thanks.
That's right.
Amazing. Thanks again for the insights there. I think one thing I wanted to ask as well, this is probably for you, Bob, and also any other doctors here. I know you've touched, Rob, on why it's important to forecast your billings. So, for example, understanding increased billings by 4%, does that then impact in terms of the valuation of your practice? I think that's one aspect to look at, but also, Bob, how do practices best control costs as well? Because increasing revenue by 4%, but then you've got CPI at 7%, and then wages at 5.5%. I think in terms of controlling costs is going to be an important factor for a lot of GP practices moving forward. Any thoughts there?
Yeah, look, I might handle this from our perspective. When we look, and this is a bit of how long a piece of string, because it really depends on the individual practice and conditions, what's happening in that practice. But some of the things that are impacting costs, and one of the big ones is, as I'm sure most of you are aware of, is the payroll tax issue, and trying to avoid slipping in to that payroll tax sort of threshold. We spent a fair bit of time trying to keep our doctors or doctor contractors out of that space. And at the end of the day, it comes down to how the contracts are written, and where the flow of funds. So if anyone has any thoughts on that or has some concerns, obviously give us a call. We can discuss that, because that's such a major cost and it adds no benefit to the business whatsoever. Don't mind employing people when you're paying tax to employ people. It's just ridiculous, but that's the world we live in. Other things to think about, obviously, are just around: do I need to have that employee as a permanent, or can it be a casual nurse, for example? Just to give you more flexibility. Our registrars is another big one that we have. Our registrars, particularly the younger ones, covering their costs and plus some margin. In some cases they're not, and we need to be able to monitor some of that. Are my rooms all making money? That's another big one. Do we have a lot of vacancies in the rooms? And if we do, and we can't fill them, are we able to recoup costs some other ways? Are we addressing no shows? That's it's you incurring that cost and someone doesn't show up, and often it's as we know, it's the same people that don't show. And how we're addressing it? Can we get our receptionist or whoever and give them a call? Are we restricting wastage for medical supplies? Are we addressing those sorts of issues? So every practice has different issues, but we do a lot of comparative work with the helps of various information we have, particularly around costs, but also with the helps of Touchstone and the likes, to be able to compare practices in certain areas to other of their peers. So if you need any help in those sort of areas, give us a yell.
Absolutely. The other one I know we spoke about earlier, Bob, was after hours as well. I mean, for most of the time, you're paying employees a little bit more to operate after hours. So is it worthwhile also charging more for billings after hours as opposed to regular trading hours?
Yeah,
things like that. I think is important.
Love to hear some maybe minutiae. I'm not sure what you guys are doing in that space in terms of, or even because you're not always able to charge what you'd like to charge, but you certainly have higher costs out of normal sort of 9 to 5 or 8 to 8 sort of hours.
Yeah, so the only time we work after hours, operate after hours, is a Saturday half day. So you can't really technically, for Medicare item number purpose, call it after hours because it's still 12 noon. But for our private business purposes, it's still a weekend. So since January this year, we made it completely private billing only. Children, pension card holders, no telephone consults. Even if there is a telephone consult, they're informed that it's privately billed. Of course, it doesn't ever work like clockwork. As you know, there's always someone grieving about, I was not informed of the cost, my kid was always bulk billed, etc. But interestingly, because when we bulk bill a private bill a kid, we bill just above the incentive, which is 660. So let's say we are not billing them 39, whatever. We're billing them around 55 or 60. So once the tripling of the incentive comes in, I'm considering not doing this for after hours. I'm going to bulk bill them. But having said that, I'm in two minds about it. Once you go on private billing, you don't want to come back from it. So then the gap is going to be higher for a mom who's bringing in a child.
Yeah.
But look, but to be fair, we advertised, we said cost of, running a practice is high. Even a coffee has a surcharge on a Saturday. So here we are working till 12. We have to pay more to our staff. So we're private billing, not too much of a fuss, but that's the only time we are going as after hours. So it's $85 for any consult on a Saturday.
Yeah. I guess it also depends on what others are doing, your competitors are doing as well.
We're surrounded by bulk billing practices, actually. We're surrounded by bulk billing.
Yeah. Well,
but it's the demographics of the practice, actually.
Yeah. And it does come down to that, being able to do some work on what you can, the others, your peers in the area are doing, and be able to compare yourself, because at the end of the day, but maybe Rob's got some information on this. I've got some anecdotal information on, how much business people actually lose by going to private practice or increasing their fees, and it seems to be anecdotally very low.
Yeah, definitely. Yeah. I think just for the essence of time, guys, I know we can go all night. It's Origin night. We've had a couple of just drop-offs then. We've gone well over time. I do want to thank everyone for their engagement this evening as well. I think it was a great webinar, great session, and a great fireside chat. Minushi, thank you so much for your contribution, Rob and Bob, and also all of the attendees. It's been wonderful having you here this evening. I'm sure Cubiko and Affluence 360 will be in touch with each and every one of you just to see where we can help support and whether you guys had any other questions as well. But apart from that, just wanted to say thank you all. Have a wonderful evening. And for those in New South Wales, go the Blues.
Awesome. Thanks, guys.
Thanks, guys.
Everybody.
Thank you so much.
Guys.
Right.
Bye.
Thank you. Have a good night.
Thank you.